How are you? Good? How is life without the heart? There's no life, right? How is the block so far? Doing well? Good. Good morning. Buongiorno. Bonjour. Sabah al-khair. Happy Ramadan to all. And happy Saudi Foundation Day. You know how I teach now, right? There is no need to go through the introduction and why I don't put lots of wordings on the slides, etc., etc. Okay? There are slides where there is nothing really to explain about. You simply read them. And there are things where there's mechanisms, and this is my job to help you through this, okay? Do you feel hot here? Why do you think? Aha, number one, it's full. So there are extrinsic factors, right? But are there intrinsic factors also? What could increase the heat in the body? Metabolism, right? Thyroid gland secretes thyroid hormones, and these are metabolic hormones. And we're going to be talking about them today. Before I go there, I have a question for you, okay? Read the scenario and tell me which answer do you think is correct. There's a person who has problem in the thyroid gland, and he's on daily intake or oral intake of thyroxines. And the question is, to which of the following does the drug bind in order to activate its cellular mechanisms of action? A, nuclear thyroid hormone receptors in order to regulate DNA transcription. B, iodine in order to be transported across cell membranes. C, plasma membrane receptors in order to activate cellular messengers. And D, retinoid X nuclear receptors in order to bind iodine. Which one do you think is the correct? A, B, C, or D? Who says A? Raise your hand. Who says B? Raise your hand. Don't be shy. C? Okay, C. D? How do you know it's A? Tell me. Did you take this lecture before? Or it's simply like it was a shot of chance, shot in the dark? All right. So I can see there are about 25 persons that answered A, right? Let's see at the end of lecture what would be the answer. Deal? Perfect. So these are the session learning outcomes. Without further dues and delays, I will not give you any anatomy and histology information about the thyroid gland that you should know by now, where it is situated, how much it weighs, how much is big. And this is simply a scheme of the histology of the thyroid gland. And I'm very much interested in this lecture today to understand what are these cells in particular doing, the epithelial cells. Usually, the thyroid gland gives two main hormones. One is called triiodothyronine, T3, and the second one is thyroxine, T4. In terms of percentages, very minimal amount is secreted as T3, mainly T4. However, T4 will be converted into the tissues to T3 because T3 is more potent and it will do the message that is relating to these cells. If you look to the histology of the gland, you have, of course, the capillaries because you need exchange with the bloodstream. And very carefully, look please to these follicles here. These follicles are one line, a monolayer of cells, epithelial cells, cuboidal cells, they look like cubes, and they line the follicle and they engulf inside them a substance called the colloid. And it's between the cells and the colloid where there will be the synthesis of our thyroid hormone. Thyroglobulin is a protein which is the major constituent of the colloid in addition to water. Let's start by talking a little bit about the secretion or the synthesis, then the secretion of the thyroid hormones. Three major axes of this lecture: how this hormone is secreted and released in the bloodstream, how we can regulate this secretion, and what it does. End of the story. This is one follicular cell. This is a colloid, and this is the interstitial space of the gland. So again, I'm going here. This is a cell, this is a colloid, and this is the interstitial space. I took one cell, I magnified it here. This cell is equipped with transporters needed to trap essential molecules from the interstitial space into the colloid to fabricate, to synthesize, to produce the thyroid hormones. The very first transporter is called the sodium iodide transporter or symporter. They go both into the same direction, sodium and the iodide. Does your body fabricate iodide? No. We take it from food. And I'm pretty sure you know that there's a salt table. It says on iodinized. What does it mean? It contains iodide because it is absorbed along with sodium in these cells. The iodide, when it goes inside of the cell, it will enter the follicle by another transporter called pendrin. This transporter will bring in iodide, will bring in the opposite direction, so it's a co-transporter, chloride ion. So iodine came with sodium inside of the cell, and then it went from the cytoplasm of the cell into the colloid as a co-transporter, an exchange mechanism with chloride. Of course, we have here the sodium-potassium pump that will bring sodium outside of the cell. But this is not the subject of this lecture. So iodide is moved now from the interstitial space. And when I say interstitial space, it means it was in the bloodstream before, yes or no?
Yes.
So it was now absorbed by this follicular cell. We call this iodide trapping. It's been trapped because it's now into the colloid here. Are we okay? This is one of the first steps of the generation of the synthesis or production of the thyroid hormones. So this is called the iodide trapping. I just explained this to you. Now, when the iodide enters to the follicle, right here at this part of the membrane, at the apical membrane, either anchored to the membrane or near to it, it doesn't make any difference for me as a medical doctor, you have a peroxidase. A peroxidase is an enzyme that will oxidize the iodide in, or we call it the iodination, and it will plug it to thyroglobulin. I told you the major constituent of the colloid is thyroglobulin. It's a huge protein that is waiting here, this peroxidase, to oxidize iodide and couple it on the thyroglobulin. This thyroglobulin is full of tyrosine amino acids, about 70 amino acids. It has so many of these. And this iodine, once it is oxidized, these are just the steps that I summarized for you here. This is a nascent iodine. Once it is oxidized, it will be moved to the thyroglobulin. It will be inserted on tyrosines. Tyrosine is an amino acid. And this is why it's called thyroxine or thyroid hormone, due to the tyrosine and thyroglobulin. And now we have amino acids here. They have these iodine on them. They are oxidized. We call this organification. These thyroglobulin are now organified. I'll continue here. Can you hear me well? So once these are organified, we have, I will not ask you any question about the chemical composition of the precursor of thyroid hormones or the thyroid hormone, but I want to explain something to you. This is the peroxidase will simply take the tyrosine, it will add to it what we said? Iodine, right? Now, if it is one iodine on the carbon ring, we call it monoiodotyrosine, or MIT. If you have two, it's diiodotyrosine, or DIT. I will just show you these back on the graph. If you have two rings, two carbon rings, two iodine inside, one outside, this is a triiodothyronine, this is T3. Now, if the two are outside and one inside, this is RT3. RT3 is found on very, very little amounts, and they don't know anything about its function yet. So it's kind of negligible. People really do not care about it that much. And the last one is T4, because it has 4 iodine on them, and the iodine are on both rings, the outer ring and the inner ring. So MIT, DIT, T3, and T4. That's all. And if you go back here, let's now talk more deeply into what's going on with the expression of these. You look right here, you see here, MIT, DIT. This is now the thyroglobulin. It has all kind of these configurations that I explained to you. Some of the tyrosines, they have 1 iodine, some have 2, some 3, and some 4. And this is why you have all of them into the thyroglobulin. And by pinocytosis, I hope you know what pinocytosis is now, there will be an increase or an extension of the plasma membrane to engulf these thyroglobulin into a droplet. And these droplets now are moved from the apical area all the way to the interstitial space. And this is how we move now from the colloid, and all these will be secreted into the interstitial space. But before the secretion, there is one more step of filtering. There are proteases that will shop these thyroglobulins. We said there are lots of tyrosines on them, right? They will start shopping them. T3 and T4 mainly are released. DIT and MIT are recycled inside of the cell. To do what? To give another pool of iodine for more synthesis later on. And this recycling is because of an enzyme, very important, called deiodinase, that does the deiodination. It removes iodine, and now tyrosine can go back to the endoplasmic reticulum and produce more thyroglobulin as a start, and then iodine can move back into the transporter through the pendrin into the colloid, and now we can have another stop to replenish the secretion. Of course, what's secreted here needs to be replenished from outside, but there is this recycling that happens here. If there is a problem with this deiodinase, a congenital malformation, this leads to decreased recycling, and therefore decrease in the secretion, in the packaging, in the production, in the manufacturing of the thyroid hormones. So what I just explained to you is very important. These are the major steps of the production of the thyroid hormones. So let's go through this quickly. Iodide trapping, oxidation. After the oxidation, we have the organification. Iodine will be coupled to thyroglobulin. Several types of tyrosins bound to iodine, and therefore all they are on the thyroglobulin. Pinocytosis brings thyroglobulin, which is already organified, into the cytoplasm. Proteases, with the help of lysosomes, will start chopping these tyrosins, and you will have T3, T4 released with RT3, and there is deiodinase that will remove iodine, and both thyroglobulin and iodine are now moving back into their stock for the next synthesis cycle. This is extremely important. Please, you need to know these, and they are very well explained to you. This is another simply summary of how this happens for your own information, and I'll get to this later on during the chapter. This is the regulation. This is also another figure for you. Consult it. Maybe it gives you more information, but the basic has been already explained, no problem there. All right, now the thyroid hormone is released. How long it will take as an effect for this thyroid hormone to start working on the cells? First of all, the thyroid hormone is a lipophilic hormone, which means it can pass any lipid bilayer, which means it can enter any cell in the human body. There is no specific target for it. And when it moves in the bloodstream, it is bound to albumin usually, and it will be released to the cells. It enters the cell, and inside of the cell, it binds to receptors to activate gene transcription. But it takes time between if you inject thyroxine in the bloodstream until the effect is seen. So this is latent period. And if you compare T3 to T4, T4, it can reach its maximum effect after 10 to 12 days, while T3, it can do it within 2 to 3 days. And T3 is more potent, as I mentioned to you before. This is, on this screen, it's a summary of 3 or more slides that will come later on. I'll simply mention them here, and then you just need to read the others. There's nothing to explain really about them, okay? But the explanation is actually here. So we said now we arrived to the target cells, no matter what is this target cell. T3 and T4, right? They arrive to the cell. They both are lipophilic. They enter the plasma membrane freely by simple diffusion. Inside of the cell, the deiodinase is waiting. It will remove one iodine from T4, and therefore it will become what? T3. T3, we said, is more potent than T4. T3 now goes inside of the nucleus. Inside of the nucleus, T3 will bind on thyroid hormone receptor. This is a protein waiting for it in the nucleus. When T3 binds on this receptor, the receptor becomes activated. And once it is activated, it binds to retinoid X receptor, or RXR. And retinoid X receptor has a very specific area along with the thyroid hormone receptor. We call it on the DNA. It's called thyroid hormone response element. This is where they bind. And then they activate gene transcription, not for one gene, for a multitude of genes. So lots of proteins will be now produced. And this is why it takes days before you start an effect of these, because the protein synthesis could be 1 minute for one protein, could be 1 day for another protein. And you can see that these proteins, once they are synthesized, they have so many targets inside of the cell to translate the message coming from T3. And this is done on different levels in the human body. Growth is affected, development of the central nervous system, cardiovascular hemodynamics, cardiac output is increased, tissue blood flow is increased, heart rate goes up, heart strength is up, respiration, and the metabolism, you know, all the things linked to the metabolism from oxygen consumption, glucose, etc., mitochondrial function. This will increase in metabolism. This increase in metabolism gives you what? Heat. And this is why people with hyperthyroidic glands always feel that they are very hot and sweating. This is one of the signs. So there is a rule about the function of the thyroid hormone. If you want to memorize them, we call them the 7 B's: brain maturation, bone growth, beta-adrenergic effect, basal metabolic rate, blood sugar, breakdown of lipids, and stimulate surfactant synthesis in babies. These are the 7 B's rule. It's for you to go through them and to memorize. So normally, usually, if you look at this graph, in normal people, if you have a release of 100 milligrams per day of thyroid hormones from the gland, this is not zero metabolic, this is zero change in the metabolic rate. So this is the basal one. If there is a decrease in the secretion of the thyroid hormone, this is hypothyroidism. Of course, there will be a decrease in the metabolic rate. And if there is an increase in the production, this is hyperthyroidism. It's the opposite effect. There's an increase in the metabolic rate in the human body. All these, please, you go through them because there is nothing really to explain about. I made a summary for you on the slides. They are well detailed in your book. This slide, this slide, this slide, and this slide, please. We get to the next step. Now we knew that the body is able to synthesize and how it synthesizes this thyroid hormone. We get to the point of the regulation of this synthesis. You know, anything in the body has feedback loops. Thank God we have this, okay? And we're gonna see this axis now and see how it regulates the secretion of the thyroid hormones. Above the thyroid hormone, right in the brain, centrally and next to the hypothalamus, there is the anterior pituitary gland. This anterior pituitary gland is a major regulator of the thyroid hormone. How? By releasing TSH, or thyroid stimulating hormone, or also another type, terminology or name for it, it's called thyrotropin. This hormone, when it is released, it has this effect on the follicular cells in the thyroid hormone glands. It increases the proteolysis of stored thyroglobulin. You know what does this mean? More release of T3, T4. It increases the iodide pump activity, or the trapping of iodide through the follicular cells. Increase the iodination or organification of tyrosine on thyroglobulin. It increases the size of the thyroid gland and the secretory activity. It increases the number of the thyroid cells. What do I mean by thyroid cells? The epithelial cells, the cuboidal cells. Not only it increases their number, but the shape changes. They become more columnar cells to tap more into the follicles, into the colloid, and to activate more or stimulate this synthesis of the actual production of thyroid hormones. And if you look at this visually, this is the hypothalamus, this is the anterior pituitary gland. When TRH is released, TSH is released, it binds on these follicular cells on a receptor called TSHR. When this bind to TSHR, TSHR is activated. When it is activated, there are second messengers inside of the cell that they are activated. One of them is cyclic AMP. Cyclic AMP binds to protein kinase A. When protein kinase A is activated, it has a multitude of targets inside of the cell to phosphorylate and to activate. Therefore, there will be increase in all these activities that I just described to you, that they highlight the mechanism of synthesis of the thyroid hormone. The iodine trapping, organification, pinocytosis, proteolysis, and secresis. All these are enhanced because of this activation of the cyclic AMP. So it's a direct effect of the SH on the gland itself. Of course, the hypothalamus is above the pituitary gland. Hypothalamus also has another hormone, TRH, that binds on the pituitary gland cells, and it will activate the secretion of TSH. So the major regulator is the hypothalamus. Is hypothalamus sensitive to temperature? It is. And this is why when you are cold, you feel cold, hypothalamus tries to increase the secretion of the thyroid glands, these metabolic hormones, to increase metabolism inside of the cell. So this is the hypothalamus. It releases TRH, or thyrotropin releasing hormone. It binds on the pituitary gland receptor. It will release TSH. TSH binds on the thyroid gland hormone, and then there will be an increase in the secretion of T3 and T4. So this is a regulation. This is another way to see the regulation with the example of the code, how the hypothalamus and pituitary glands will lead to this regulation of the secretion and synthesis of T3, T4. Pharmacologically, there are several ways to regulate the synthesis of thyroid hormone. What I wrote here for you is on this scheme. Okay, so I'll explain it here because it will help you more understanding things. Thiocyanate, perchlorate, nitrate ions, all these inhibit what we call the iodide trapping. You know about this mechanism now. Propylthiouracil, metamizole, or carbamazole, they all inhibit the binding or the organification of the thyroglobulin. And high concentration of iodide will inhibit the pinocytosis or the endocytosis. Doctor, you just told us that iodide is important. So if we increase the concentration, we should be increasing all this. Yes, every physiological mechanism is between two zones, lower limit and upper limit, and we call these limits. So when you go with 100 times concentration of iodide, you already bypass the physiological limit, and therefore there will be an inhibition of this endocytosis. The last thing, I'm going to give you examples on abnormal thyroid glands. So you know hypothyroidism and hyperthyroidism, right? Okay, very quickly, let's take an example of hyperthyroidism. What could lead to a hyperthyroidism? Cancer in the thyroid gland, this is one. Two, an autoimmune disease called the Graves' disease. In this particular case, it's an autoimmune disease. The antibodies are directed towards the thyroid stimulating, we call it thyroid stimulating immunoglobulin, or TSI. They are directed towards the TSH receptor. So when they bind to the TSH receptor, they activate the TSH receptor without TSH hormone. So when they activate it, there is an increase in the cyclic AMP production, and there's a huge production of T3 and T4. And because there's a huge production of T3 and T4, guess what? The anterior pituitary gland will not release more TSH, right? Because it's not needed. But it's artificially manipulated by these antibodies because it's an autoimmune disease. Thyroid adenoma, sometimes in the thyroid gland, you have part of the gland that has adenoma, cancer cells. They are proliferating, they are producing T3 and T4 in large quantities. Who sense this high increase in T3 and T4? The anterior pituitary gland will say, this gland is producing normally. Why do I need to increase TSH? Let me shut down TSH. And anterior pituitary gland will do this. By shutdowning TSH, you will have a deformity in the gland where you have the adenocarcinoma, you have the gland bigger and producing, and where you don't have, which is a benign area, it will atrophy. Why it will atrophy? Because it's not getting any stimulation from TSH. TSH is shut down already. So it will not be stimulated to produce more T3 and T4. If a person is hyperthyroidic, usually he has a high state of excitability, intolerance to heat because it's already at high metabolic rate, increase the sweating to liberate the heat, mild to extreme weight loss, varying degrees of diarrhea, muscle weakness, nervousness, extreme fatigue but inability to sleep, and tremor of the hands, shaking because of the high metabolism in the muscle cells. One of the signs of hyperthyroidism, another condition, is where a person has a goiter, and because of these TSI, those immunoglobulin attacking the TSH receptors, actually they don't only go there, they're in the bloodstream. They start attacking the optical nerve. And this is why a hyperthyroidic, sometimes at extreme cases, has a protrusion of the eyeball. And in extreme cases, this attack can destroy the optical nerve and the eyeball can bulge to the outside. And we call this the exophthalmos. The opposite, in hypothyroidism, the autoimmune disease is called Hashimoto disease. In this particular case, the antibodies will destroy the follicular cells, which are the manufacturer, these are the factory to produce thyroid hormone. And this is why T3 and T4 will be less. What will happen to TSH? Very high. It may result in goiter because part of these glands are destroyed. The other part are not destroyed yet. They are responding to high levels of TSH. There will be hypertrophy in these cells in this area. It will result in goiters as well. The goiter will be generated, and these are what could cause hypothyroidism: deficient trapping, deficiency in peroxidase or mutation in peroxidase, congenital malformation. I'll talk to you in a second about it. Deficient in the organification or coupling of the iodine on the thyroid gland, thyroglobulin, and a problem in the iodinase enzyme. All these could lead to hypothyroidism. Please, you read these. There is nothing to explain about them. These are the signs and symptoms of hypothyroidism. Myxedema is a condition whereby you will see, in the complete absence of thyroid hormone, bagness under the eye, swelling of the face, and sometimes edema in the extremities. This person has no thyroid hormone, so basically the metabolic rate is at very, very minimal values. And the most driver of metabolic rate is absent from the body. This person has to be on daily intake of thyroxins. And people with daily intake of thyroxin live to their 90s. There's no problem with this, as long as they keep on taking it every day. This is a treatment for it. One very important condition, it's called cretinism. Cretinism is hypothyroidism at birth. Okay? But get this, please. I just showed to you that it takes about 10 to 12 days for T4 to reach its maximum metabolic rate. I showed you also for T3, it's between 1, 2 to 3 days. But you keep in mind, please, that the thyroid gland, even if it stops secretion or synthesis of thyroid hormones right now, the thyroglobulin, the stock made in these cells, is good for another 2 to 3 months. Okay? So whatever metabolism this fetus got at birth is still getting a stock of this from his mother. So of course, people will not immediately realize at birth that this person has a low metabolic rate because it won't show like this. If this is not treated, this cretinism, of course there will be defective malformation and development of the central nervous system, musculoskeletal system, etc., etc. And they have to be on thyroxine for life. These are the covered topics today. And now it's time to answer the question again. This person has a problem with the thyroid gland. It's not secreting thyroid hormones. And the person is on daily intake of thyroxines. Where would thyroxine bind to increase its metabolic rate? Nuclear thyroid receptors in order to regulate DNA transcription, iodine in order to be transported across cell membrane, plasma membrane receptor in order to activate secondary messengers, or retinoid X receptor in order to bind iodine. Which one? What is your answer? Who says A? Raise your hand. Who says B? Raise your hand. Who says C? Raise your hand. Who says D? Raise your hand. So who says A? Again, raise your hand. Why I have less responses than the beginning of the lecture? It defeated the purpose of the lecture. So it is A, okay? Of course, the retinoid X nuclear receptor will bind, but not on the thyroxine. It will bind on the receptor to thyroxine. And they bind on the receptor of thyroxine to do what? To enhance what? Transcription, not to bind iodine. Iodine has nothing to do with the target cell at all. Iodine is at the thyroid gland, follicular cell. Okay?
Yes.
Are you okay with this chapter?
Yes.
Very easy. 3 main things, please. You focus on them. The synthesis cycle, the actual regulation of the synthesis cycle, and the conditions, hypo-hyper. Any problems here? Anything unclear? Are we ready to take the attendance?
Yes.
All right, let's do it.